Welcome everyone to today's webinar, How to Build a Patient Navigation Hub and Retain Patients in Network, Real-World Insights from Two Experts. I am Brian Zimmerman, the Custom Content Editor with Becker's Healthcare. We'll begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Our presenters today are David Wildebrandt, Managing Director, BRG Prism Healthcare, and Austin Potter, Associate Director, BRG Prism Healthcare. At this time, I'm pleased to turn the floor over to David to begin today's presentation.
Yes, thank you so much. I guess good afternoon to most of you, maybe a few of you. Good morning. Certainly, first and foremost, in appreciation of how complex and busy our environment is in healthcare, just a really sincere thank you for joining us. I think it's all good for us to, kind of pause for a moment and try to learn together. I think hopefully you'll see from Austin and I that we're not here to be prescriptive. It's just sort of lessons learned, and I always say true experts learn from others' mistakes and not their own. So I think we've cut our teeth several years on doing this type of work, and so we're just happy to share with you all and have some time with you to kind of talk about what we think is a very important area and just some of our learnings. I would just briefly say for BRG Prism, we're a performance improvement organization. We have what we call a subject matter expert model. We have folks that have worked, in different parts of the industry for many years, and that we bring together. So at our core, we're an implementation group. So, for example, Austin and I and our team, we're out at health systems and provider systems every week working. So we don't work out of an office or work just advisory. So we're actually on, boots on the ground type folks. We pride ourselves in analytics and the quality of our people. And again, just really glad to have this opportunity, and I appreciate the folks with Becker's putting this on today. So just to give you the sort of the big picture overview. I think for today, we want to talk about the fundamentals of referral management, and so and kind of unpack that a little bit on some of the vernacular that may be familiar but may be new. And then more importantly for us, it really is around not admiring the problem, but what have we learned, what have we seen work, sort of some of the characteristics of success. And we kind of do this through an evolution. So what we started to do was to build out central referral offices. And for the scope of this part, this is around, in physician practices referrals. And then how to evolve that to a patient navigation hub, which, just doesn't happen spontaneously. It would be very purposeful. And then lastly, talk about, sustainability and the governance around, what we call network integrity, and some of the performance measures. So, I don't know if you all are seeing this or if you agree, but even in, one hospital markets or non-competitive markets, we see quite a bit of patients that originate from within the what we call employed or aligned or loyal physicians that somehow end up getting care outside of that organization. So, in our work, we see from employee primary care, referrals that are coming directly out of those practices, sometimes up to 47%, sometimes greater, so not always this, but on average, going out to other subspecialties. So these are direct referrals, and that's employed physicians, right? So you see some of those referrals. And then on some of the affiliated independent physicians, even greater, often 61 from our data. And just for example, on a cardiovascular sort of a blended value for a referral, that can be $3,244 each referral. And then there's a cost, for when you leave the organization and you're in value-based contracts or part of the attributable lives, there's a 22% cost premium differential as those patients are not being managed on a total cost of care. So our approach today, just to kind of lay out the big picture, is we will start with referral management. And the way I would describe this is more of the infrastructure, right? What are the initial steps if you're going to deploy this program in terms of that it has to be an iterative process. It's really, it's not something you buy your way in. It's really a culture change. And then moving to what we call a centralized referral office. Austin will really get into some detail in this area. And then I'll come in and talk about, hey, beyond this, you kind of the old begin with the end in mind. How do you build this that's scalable? That really brings together sort of disparate parts of the healthcare system. So that's going to be our flow that we use today, and we'll certainly have time at the end for questions if there are any. And so I'm going to pass it off to Austin to start on some of the referral management infrastructure.
Thank you, David. So now that we understand the problem and the imperative for change, the question is really, what do you do about it? And so David outlined our discussion and the flow, how we'll talk about referral management, really the business case for a central referral office, and finally the evolution to a patient navigation hub. But the first piece here are the fundamentals of referral management. And really, the most important element to referral management, like most comprehensive initiatives in any organization, is buy-in at all levels of operations. So this truly is a journey of change management at its core, and every level of the organization, from the executive team to medical group leaders, the medical staff, whether it's ancillary department directors or practice managers or service line leaders, really need to be bought in and ready for the initiatives. So we've broken down referral management into three main categories, which we'll use as the agenda for this first piece. The first is data. So we'll discuss a bit about claims data, when to use them and when not to use them, and really how to apply them to this process. Then we'll move into the importance of optimizing your process flows and developing a single provider directory, and then aggregating data to show provider utilization and loyalty. And then last, we'll discuss the strategic approach to provider outreach and how to set priorities. And this really involves the use of physician champions, as well as having a governance committee to address these barriers. So before I move on into the detail of this area, just a few questions that I think should be on the top of your mind as we enter into this, as you're thinking about your organization and we present today, are really, how does your organization close the loop on referrals that are made today? And how does your organization manage referrals from independent community providers? And how are you ensuring that your process that you have in place is collecting useful data to be able to aggregate and analyze? And most importantly, how do you change your processes with minimal to no impact on providers, while also really significantly increasing access to patients? So first, we look to optimize the EMR. This is not hard work. It's not rocket science, but it is absolutely tedious. There are a lot of stakeholders that need to be involved. There's a lot to work through with IT. It will utilize a lot of time, a lot of resources, and it is certainly hard to maintain. But the takeaway here is usually when we enter into a new organization and we're looking into this, what we'll find is that looking at the EMR, there is no standard referral status. So there isn't a standard of what's a routine referral versus an urgent referral versus a stat referral, or the EMR won't have hard stops in it that require certain data elements to be filled in before moving forward. And so really focusing on making sure that there are clear definitions, and if something is going out of network, do we have the reason codes in a place to capture that? Now going back to the definitions for a second, if every referral is a stat referral, then no referral is a stat referral. So sometimes, working through educating your providers in terms of how to place referrals into the system is important. So let's talk a bit more about that single provider directory. This is probably one of the biggest areas of opportunity for organizations. A lot of times when there's different provider directories, whether you look at the practice management system, if there's a different EMR for the ambulatory sites versus the hospital side, or if they're between credentialing and medical staff rosters, a lot of times organizations will have different provider directories. Where we see it most prevalent is organizations with large clinically integrated networks, whether it's an ACO or a PHO or an IPA. That group will have an entirely different provider directory of who's in network and who's out of network than the health system or the employed medical group. So really making sure that we align that. And that doesn't even take into consideration all those cheat sheets that are out in all the practices that providers look at day to day to figure out who they're going to refer to, and making sure that those are updated and in the right hands. So that's our focus in terms of putting a provider directory together. The other big piece to that is looking past the ambulatory space and looking at your inpatient floors. There's patients leaving your hospitals every day with orders and referrals, and making sure that they're utilizing that same provider directory, as well as those patients that are leaving your emergency departments. A lot of times we find that even when all of this great effort is put into place, the doc and the ED picks up the phone and asks who's on call, and that's where the patient ends up going to. But those providers who are part of your on-call schedule might not necessarily be the most loyal providers to the network or who you want to be sending all your referrals to. So really making sure that you have a complete lens and insight into your provider directory and map it all back to one single source of truth. So earlier I mentioned we would discuss how best to utilize claims data and when to use it and when not to. And the big takeaway here is understanding the use of claims data, right? Claims data were not created in order to necessarily understand referral patterns. That's not the original intent of claims data. And so realizing that they're just should be used to demonstrate relationships between individuals. It's connecting data points for you. It's giving you the macro lens of what's going on in your market, and really making sure if you are utilizing claims data and that's your source of insight into referral patterns in your organization, is making sure you have balance between refining the data and analyzing it so that it's useful for you, but also making sure that you keep data manipulation to a minimum. Because as soon as you start to manipulate data integrity too much, it will really deteriorate the integrity of the data. So claims data is directional at best, and in best case scenario is that you have a complement of both EMR data with claims data, and we'll talk about the EMR data piece when we get more into the CRO portion of the presentation. However, we do understand there are plenty of markets where you may not have employed providers, or it's prevalent with independent physicians, or there's 40 plus EMRs in your market, and it's just hard to mine all that EMR data, so you do depend more on claims. All we're saying is when you're going out and sitting down with providers to talk about referral patterns, data straight out of the EMR tends to be much more useful than the claims data. So now that we understand the data elements, what strategies are best practice for provider outreach? David, I'm sure, will back me up when he gives a summary here in a bit, but I would say the single most important thing that we focus on is peer-to-peer physician outreach. When you're going out and having conversations with providers about referral patterns, whether it's the consultant going out, which David and I do every day, or it's the CEO of the organization that's going out and meeting with the most disenfranchised providers, or the practice managers that you're holding accountable for meeting with their providers and making sure they understand referral patterns, or even the CMO of the organization. Nothing is as impactful as having peer-to-peer physician outreach, having a primary care physician go out and speak with another primary care physician, or a cardiologist go out and speak with another cardiologist. And it doesn't necessarily need to be the same specialty, but a specialist to a specialist will always have a bigger impact on understanding not only referral patterns, but the importance of keeping patients within the network and what the value is of that. Part of those conversations is also having an issues log and logging and tracking any of the barriers that may arise or are shared by those providers when you're meeting with them. I've actually had providers tell me, why are you here to talk to me about referral patterns when I've been trying to get my printer fixed for 6 months? So you need to be logging those issues. It's not necessarily your responsibility to fix all of that or put out operational fires every day, but that stuff should be logged, and it should go back to a dedicated referral committee that's making sure those issues are being followed up with. And really, that's what the dedicated referral committee is. It's a governance group that has a relentless commitment to removing access and quality barriers in the system, and is focused on this outreach. And lastly, part of that group is to make sure that on a monthly basis we're going out, we're meeting with providers, we're showing them the referral patterns, and it's not a hammer approach where you go out every month and ask specifically, why did this referral go out of network, or why did that referral go out of network, but just making sure that providers have the information in front of them and understand where their patient population is going for care. And a lot of times it's eye-opening. They just haven't seen it before, and they're sort of shocked by their own data. And it just promotes even greater conversations to have. So with all of that being said, and I guess since we've now set the expectation for what the health system needs to do, there also needs to be a little bit of reciprocation from the providers, right? So here we are coming out as the health system, and we're saying, listen, we are completely dedicated to investing in resources, investing in technology. We're going to promise to keep you informed, timely, have honest communication with you, remove any EMR barriers where possible, but we need stuff from you in return. And what we need from you is to make sure that we have simplified scheduling, that we have access to your schedules, that we maintain services within our health system where possible, strong documentation in the EMR, and that we're respecting the definitions of what is routine and stat and urgent so that we can get our patients in for the care that's needed at the right place at the right time. And really, part of it goes to the extent of really, if you want our referrals, we expect you to see our patients timely, to open up access, and to close the loop, and make sure that you're sharing those summaries of care. So varying organizations will implement something like this, and some folks have actually made their providers sign that as like a formal document. Other organizations just kind of share it as a more loose expectation of, look, this is what we're doing for you, so this is what we expect back in return. And it just helps to really kind of set the expectation and set the stage and go out and act as an agenda for conversations with providers. So with that, I'll turn it back over to David.
Yeah, just to add to this, like real life examples of stuff we see, one of the common areas, are GI practices, because of real common physician shortages, the amount of demand on those areas. If you have a group that's within the system, some of the work we've done with the compacts, and the reason why we call it a compact is we really are, trying to make this a collaboration, a partnership, not a contract per se. We'll have a GI practice that will open up, 25, 35 slots a week just for the primary care group. because that's based off their normal need and use rates and things like that. And that way, that's a very seamless process, for the patient. And I know you heard Austin mention the word access and quality quite a bit. And that's just something, we hope if there's a couple things you get, that this really is around, this is about putting the patient at the center. All of this is not just a revenue play or a per click. And a lot to unpack here, right? But there's other, we've seen and we've tried early on when it was more of what I would call a big brother approach, where you would just sort of stare the problem down and use more sort of behavioral modification or even just awareness tactics or campaigns. It just didn't work, because in reality, there's good reasons often for the referrals to go outside of the system. There's not good communication. There's not good access. There's physicians that may have quality issues, and those just or anecdotal. But one of the things, in a referral management, it really gets at the heart of the patient experience, and it solves for these. So you'll see, just in summary, again, a lot of things that are done in a referral management, building out the infrastructure. Austin's going to go into some detail about our biggest solution, which is the centralized referral office. That's probably not a strange concept to many, because years ago in the health system, when trying to schedule patients into outpatient departments and other departments, we saw the advent of the centralized scheduling area, which is the scheduling of the patients, and that was removed from those departments into a centralized area. Similar thing here in the physician practices. We mentioned the peer-to-peer outreach. There has to be ownership. We bring the physicians into the front. We don't design it and then ask for a physician champion at the end. And I can't say enough about the access summits. Really, the people that are closest to this in any sort of a lean or any sort of a Kaizen environment, it's the people closest to the problem, and that's the front office staff. Now, those can vary. Sometimes it's MA, sometimes it's clerical folks, schedulers, even clinical folks that are doing this. And one of the things we say that's still probably surprising, we can go into 10 physician practices and it's done 7 different ways, even in an integrated delivery network. But the front office staff are key. We really involve them into a sort of a blameless, faultless environment and say, hey, what's going on? We have these half-a-day summits where we bring them off-site, almost like a planning retreat. And I would just say it's really a great way to get a lot of information. But we break into groups and we help, solve for it. Again, it's about really how do you correct this? The referral tool, which is, again, the true north of all of this, a goal without a plan is just a wish. So how do we make sure that we're anchoring this, empirically, and that we're actually, driving the results? Austin mentioned the barrier tracking and the reason codes. That's very valuable. If you see the reason code showing up as, 30% patient preference or a previous relationship, then we know that that's just a workaround. That doesn't follow the norms. Clearly things like that matter, and this is not about removing the rights or the scheduling folks entering over into clinical decision making. But it is about making the access and quality so strong that it's a drop off if you go to another system. And then the governance is critical. It can't be a one-off sort of initiative. They have to see this every month and have the metrics reported. So, and again, this is one piece, right? So you can imagine as you're going through the referral process, the access is very critical. So it's not only, the upstream, but the downstream side. So I'll pass it back to Austin and talk about some of the problems we're seeing with access, which can kill a referral management program.
Yeah, so before discussing the solution and the function of a central referral office, I do want to make clear why it is needed. And you see here, 46% of faxed referrals never result in a patient visit. 42% of physicians never know if their patient ever even saw the specialist that they referred them to. And those are real numbers, and we see that all over the country in many organizations and many different networks. And so those statistics are pretty staggering. But I do want to add on to a few of the comments that David was making before moving on. And I think the point here on what the focus is that the goal of doing this is not to persuade or convince providers to refer to you. And the goal is not to reconfigure your systems and processes to make out-of-network referrals difficult. The solution is a real commitment to building a referral process that is the most preferred process in your market, the most efficient and effective referral process, so that providers want to come to you. You are the most efficient health system. And so with the central referral office, basically the message there is look, we'll receive a referral any way you're willing to send it to us. If you want to fax it, fax it. If you want to call us up, call us. If you want to send it through the EMR, we'll take it, we'll collect it, and then what we'll do is put it into a centralized work queue, and we'll ensure that your patient is matched with the best provider based on any preferences that you communicate to us as the health system. So whether that's a gender preference or a specific insurance need or a certain language that needs to be spoken, whatever those factors are that need to be considered, we will match your patient to the most appropriate provider. Not only that, we'll take care of the pre-authorization, and we'll be in contact with your patient to make sure that they have a scheduled appointment. And sometimes maybe that doesn't happen, right? Maybe we reach out to the patient 3 times and are unable to contact them, or they just simply say, they tell us that they don't want to follow up on that appointment. Well, you're communicating that back to the referring provider so that they at least then have the notes in their EMR the next time that patient comes in, or if they want to make their own follow-up call to that patient to say, hey, look, I see here, they tried to contact you 3 times, they're unable to get through, or you said you were going to schedule your own appointment. Did you do that? I want to make sure you're getting this care, and it really allows for you to close that loop with the referring providers. So with that being said, now that you have all this new referral volume, where is it going? So we've made all these promises, we've developed all these workflows, we're being true to our promises, and now the floodgates have opened and the referrals are coming through. And we need to find room to schedule these patients within the health system. So we put this in here to make sure that we're looking at both sides of the equation, and just really to make sure you're aware or considering there may or may not be misaligned incentives in your organizations that favor new patients over existing patients, or where you're bumping existing patients and established patients further out in order to schedule new patients in, and that's not necessarily helping anyone at the end of the day. Making sure you have good insight into no-show management, which the central referral office will actually help give you further insight into, because they're tracking your patients through every step of the process, so you know where they are in that scheduling life cycle, and if they don't show up for appointments, the CRO will have that data. And even more importantly, what is that pull-through rate? What is our conversion of referrals and calls into appointments? Making sure that we're tracking that over time and being more successful in making sure that referrals made turn into actual appointments. And then lastly, of course, capturing new patients. So whether they're coming out of your emergency room or coming off your inpatient floors, or just new patients to your health system in the ambulatory network, making sure that we're scheduling them appropriately. So I will turn it back over to David to really talk about how you move from focusing on referrals and authorizations and really evolving that into a patient navigation hub, which has many more elements to it.
And I bet you thought you wouldn't hear the term fax today, but believe it or not, I mean, we have a client now in Louisiana that is still using handwritten orders, not even to the level of fax yet. As they're going through EMR conversions, It's defaulted back to that, and not only is there no queue, there's no feedback loop for the patient. So again, it's you know, some systems have done a lot in this area, and those that have had may have a good referral management process in place, but then sort of, you know, what's the next tier? Now, I don't know about you all, but I'm a coffee snob, so I figured that's like one of the few things in my life I control. So hopefully you're having some right now. But, you know, if you think about healthcare and what it's like for a patient, if you had to go to one place and buy the beans and go to another place and grind them, then go to another place to have them brewed, and then at the end you didn't get a bill and maybe it would arrive sometime later in the mail and you have no idea what that would be, that's what it's like for patients. So when we talk about elements of a patient navigation hub, I think it's just the principle that, you know, problems do not line themselves up in organizational charts. How we organize ourselves in healthcare has been somewhat not patient-centric. And so when you look at the patient navigation hub, it's not so much as a brand new build or just, by the way, none of this is very capital. It's not a capital play. It's not a big FTE play. It's a coordination and a workflow play, right? Because a lot of these departments are here. So in the patient navigation hub, when we move past the CRO, in other words, the CRO is that one component of scheduling the referrals out of physician practices, both referrals to other physicians and to diagnostics or inpatient care. So also the scheduling and authorization piece. Why would that make sense? Simple, you know, or similar to what you do in registration, where you have those folks kind of hand off so the patient, you know, how to move through the process seamlessly. It's very important. Well, in today's world, I know we have a lot of folks from the care coordination role on the call, and you know, that is just paramount. One of the most complex, critical areas of it all that really are touching every aspect of the, you know, clinical care, revenue cycle, you know, the overall quality of the patient and transitions of care. So that department is also, you know, has a big role here. It's making outbound calls or, you know, again, doing the things to get a good transition. And then, you know, on and on, right, with the customer service access centers, whether it be, you know, other referrals where you kind of have a strategic relationship, after-hour calls, nurse triage, you know, prescription refill. And what we're saying, we're not saying at every place that you go and have to do, you know, this big, huge, you know, 20,000 square foot department and put all these departments together. Sometimes maybe that could make sense as much as it is, you know, are really all on the same platform? Are they talking and working together? So as you look at the next slide, I mean, this will give you an example, and this is not far-fetched to what we would see. So some organizations, again, don't have any of these areas, right? Don't really just leave the referrals up to the physician practices, however they may happen. You know, one practice at a time. Sometimes they do standardized things across that. But then you'll see, you know, an access center that could be a separate, you know, sort of what we call phone banks or group of folks that are, you know, are touching, you know, communicating to the patient or have touch points with the patients. You'll see the referral team, and again, you'll see the things that you normally have in the clinic phone banks. And this is all just standard, you know, operations that have to happen, the blocking and the tackling in the practices. And then again, what about the handoff to centralized scheduling? I mean, if these patients are going to cardiology, you know, for a GXT, or they're going to outpatient physical therapy or wound care, whatever it may be, you know, what is that handoff like from referral? You know, again, all of these areas are usually divorced in the health system, even under different leadership. And then all of a sudden, we have the organizations that are pursuing value-based care, and then you have a whole other group of folks that are reaching out, touching the patients, and sometimes in an entirely different tax ID number legal entity. And you have care management, you have gaps of care, you have CCM, TCM, all the things you're doing, reaching out to do AWVs and annual wellness visits. So it just doesn't make sense for these organizations not to, you know, share staff. Especially there's a lot of non-clinical staff involved, and some of those same skill sets that are working on these maintenance teams and others can work on these other organizations as well. And so one of the things we'd like to talk about is, hey, how do you win in both worlds? I'm sure many of you work in organizations that are balancing between the fee-for-service world and the value base, and how do you make that transition? So, and what we like to think is, a lot of these, there's still a lot of improvement. By keeping patients in network, you can do the AWVs and the transitional programs. We're paid off quality, right? Both in our normal book of business that's contingent on quality, even fee-for-service, and the value base. You're certainly not going to be able to close the quality gaps or hit your measures, which could be different for each payer if you don't have them in network and navigate them through the hub. And then, again, can't impress enough about the importance of the care coordination team, and not only the things they do, episodic to be notified when a patient has an inpatient event, but even the ambulatory management of the patient. So again, a very comprehensive program to put into place, which is at the core of healthcare, though. It's transition, it's talking to each other, it's making sure the patient doesn't fall between the cracks by hardwiring this. But we said earlier, Austin, none of this, matters unless we know what success looks like. So we have to have strong analytics. So I'll turn it back to you to discuss some of the things that you may want to look at. So.
Okay. Well, thank you, David. On this next slide is really to just show what this allows. So now you've built this patient navigation hub, and David talked about how that really, patient satisfaction and provider satisfaction, and really, putting together a strong care coordination platform. But that's now going to give you all of this data that you can now utilize to truly understand, and it's coming through your EMR. So it's not claims data, it's not looking at 4 months or 6 months in the arrears. This is yesterday's activity. And it allows you to then understand, of course, as high level and general as you want to look in terms of a summary of what's going in network and out of network, but then starting to drill down by clinic or referring group and understanding, okay, now when I break it down by office, in what markets do I have the most leakage, and is it because I need to add certain specialties there, or is it because a certain payer isn't prevalent that I need to put together a relationship with, and what are the reasons? And then you can, again, drill deeper and go and look in by individual referring provider and understand each one of their referring patterns, and take away valuable insights that you can then go out and have conversations with. So, what are your top out-of-network reason codes? And David touched on that earlier. There's a big difference if it's geography and insurance-based versus patient preference or provider preference. Those are two very different issues that would need different strategies in order to provide solutions for. And are there certain specialties where we just see, maybe in 1 or 2 specialties, that's where it's prevalent in outmigration, or maybe it's just a service you don't offer, and you see how many referrals are going out of network, and it may make the case to look into building that service line or not. And then looking into all of the other, data elements that you can drill down into. And lastly, really then trending. And you want to trend your progress and report out on it. That's what people get excited about, right? So understanding the dollars that are connected to this and the ability to show your total value of leakage, which David will talk a little further about in a second, and really tracking the value of leakage by provider and watching that trend line, that black line of leakage, come down month after month and keep more patients in network. So this is just some insights into the type of reporting that you can pull together from your EMR data once this is in place.
Yeah, and I think, one of the things that we wanted to impart on you is that, we're just very bullish about, this type of data as a major KPI in the health system. I mean, if you think about it, we spend all of our time in health systems really managing what happens downstream. What comes in the ED, what happens, and folks that are bringing elective surgery cases to our organization, and we look at everything retrospectively. When really in a covered lives situation or a patient attribution model, I mean, the majority of our volume is in the physician practices. So we really like to see organizations that have, strong analytics around referrals at the same prominence as you see, ED visits, inpatient admissions, or surgeries. So again, that's why the investment in the data. So when you look at the value referral, I think, why is this important? Why we're bringing it up? It's not all about the economics, but, really everything in today's world, what's the ROI? You all are very aware, and I'm sure it's like this in your organization. You can't just have the intangibles or soft results. And I would just summarize by saying, the patient moves through a continuum, and there's all kind of ways to look at a patient. You could say, hey, if you recaptured a cardiology patient and we go into another system, that could be a patient for life. They're very much usually will continue to utilize in a system and remain very loyal. But for us, we really look at really not doing this in the macro or a swag, but literally looking at the pull-through rates. And otherwise, if a patient is referred from a primary care to an orthopedic surgeon, how often does something happen and at what rate, and what's the revenue around that? Is it 20% of the time they have an MRI or a procedure? So we look, at the real patient data. We establish, sort of a use rate of downstream services, and sometimes it just could be professional service, sometimes outpatient, or sometimes inpatient. Sometimes we'll bring the claims into it, so we have a real revenue look versus just a average contribution margin. But at the end, we do establish a value of a referral, and so that there is a agreed upon benefit methodology that says, hey, every time we recapture a patient into our system, we certainly applaud the improvement in access and quality, but here's the value of that referral. But probably even more, certainly equally important, is the ROI and the value-based care. So again, I would say, and many would have agreed or opined on this topic, that the single biggest lever in a value-based contract is in-network, in-network keepage of the patient in terms of making sure they do not seek care outside. Because first and foremost, you're not getting the quality checks. And those payment models are contingent upon those quality measures. They're tough enough to do even if you get to the patient in your own clinic more or less, fully losing control. You certainly have lost the care and utilization management. You can't really reach out to the patient to do gap closures in the care. But probably more importantly is the continuity and coordination. I mean, we're nowhere near having a community health record or really get interoperability where we can see what happened when that patient leaves the system. Most of us in health systems have been blind for years to what happens after they're discharged. They could go to a number of places. So again, it's about keeping them in the system. And again, I won't hang out here too long, but again, we've certainly spent a lot of time, over the last, 5 or 6 years, working in this area with organizations, and we've seen, some of the larger systems, establish up to a 40 FTE patient navigation hub that really reduce off a large group of patients, a 14% reduction of patients out migrating, which, when you look at the value of the referral, was a $21 million, accretive gain to the organization. We've worked with clinically integrated networks who usually embrace this a lot stronger because they usually appreciate the total cost of care play and the value base, folks in this area to help improve quality measures. Austin, talk about the Children's Hospital engagement, which you actually led. That was, very positive.
Yeah, we actually implemented a central referral office at a children's hospital where they actually did not employ any primary care physicians. They were a specialty hospital, so their main focus was how do I get all of those independent pediatricians, primary care physicians out in the market to refer to us versus the competitors. So we kind of turned the model on its head. Instead of understanding where the referrals are going, we wanted to make sure that we could receive referrals faster and easier and in any way, shape, or form than any other competitor in the market. And they put together a rather small team, six FTEs. In 4 or 5 months, they actually saw a 26% increase in new volume to the system. So it was pretty impactful.
Yeah, and then, working with large independent physicians groups, which sometimes are reluctant, to engage in these type endeavors, especially when it's not all about the dollars, but we've had some success working to keep patients in network, resulting in $7 million pickup to the organization in margin. But again, most importantly, every one of these examples, it was really about improving the access and the quality, and really hand-holding the patient through what used to be a very fragmented, disparate, group of departments, and so it was a win on many levels. And again, I will sort of end where we began with a heartfelt thank you. I certainly I wish we were all together, and appreciate you sticking with us on a webinar, and hopefully we would help you in your journey in kind of whatever problems you're facing, and there were some wins and things you can borrow from us, and lessons learned. So I know now I'll pass it back over. I think we possibly may have some questions.
Yes, thank you so much, David and Austin, for that great presentation. And we will now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we can. We've had a bunch of great questions come in already, and we'll get started with this one. So this attendee asks, most health systems have implemented provider outreach programs. How is this any different?
Yes, so I think that's a great question. And I think, that in and of itself is almost the answer. I think an outreach program is one component of what we're calling a referral management or patient navigation program. The difference would be, if you go and do outreach and you have liaisons for folks that go out in the market and they find out, hey, we don't send you imaging because we don't get a report back, or we don't send you cardiology because it takes us 5 weeks. Often the outreach folks, they discover valuable information, but there's not an infrastructure or a bigger program to correct those. So what do you do about it? So I would say that an outreach is more of a discovery process, and it certainly helps, and no indictment on those programs. But the bigger difference is here we're actually involving the physicians and managing this out of a centralized hub so that you can hardwire, some of the corrections. So it's just another, huge level of commitment. So.
Thank you for those clarifications there. And the next question I'll ask is, how would this work in an ACO environment, and how do independent physicians or their care management teams participate?
Yeah, great. So, now, it's funny when you talk about the regulatory environment, and certainly I spent 17 plus years in a hospital role, and at one point you couldn't even put some of the sort of practice losses and referral data on the same page. There was just so much regulatory issues around it. But there's been a great appreciation and a big departure from some of the rules that didn't make sense. And again, in no way, I should say this every time, would we ever suggest any consequences of pay or performance or job of physicians related to referrals or any sort of inurement. This is around the patient. So what you see now is penalties, for patients that leave out of network. More commonly, and so because the appreciation that you can't control the quality and the cost, so the ACOs usually embrace this a little bit quicker. They may not have the infrastructure or the staff and other things to deal with it, but they certainly get the concept. So in an ACO CIN, it's very similar. It even can exist. Between the CRO can be in the health system and serve the ACO CIN. If you have an MSO type model or a shared services agreement with that group, and then you get more with the independent physician. So that requires sometimes there's a use of some scheduling software that all the physicians in the ACO CIN will use, so that there's some standardization. And then those patients are scheduled through the patient navigation hub, just like the employed physician patient. So.
Great. Thank you so much. The next question we have here is, can you talk about the ROI for referral tracking in this way? How can providers convince financial leadership that this type of investment will lead to cost savings?
Yeah, well, that goes back to, again, if you're in a fee-for-service environment and, you're not creating additional utilization, this is volume in the market that you're missing. So we're not shy about saying, hey, top-line revenue growth is still very important. I mean, we're all growth people, in health systems. So, and that was the point of the value referral. I think, unfortunately, a lot of organizations and companies, including ourselves early on, did it poorly. Didn't really invest in a good benefit methodology of how you track it. But so I think you start at the highest level and say, all of us, I would hope we would agree that patients that were, originating in your own service area, in your own subsidized or aligned physician groups, and then end up getting care. I mean, that's what we did. We subsidized the competition. So there is a value to those patients coming back into the system. And for us, it really is showing that financial relationship at a very specific level. And in fairness, just having sort of a value referral that's just based off of, some ubiquitous margin number or, a benchmark number versus, hey, this is the actual use rate of those patients in our system, and here's the actual margin or profit on those patients in our system, so that it's again, not done at some nebulous benchmark level. That's that takes an investment in scoring these, but that's the play.
Yeah, and I would just add, David, that it's really not much of a financial investment. I mean, most of the people are already doing these tasks, as you talked about, within the health system somewhere. This is actually making it more efficient and coordinating that and coming up with those economies of scale. And so there's minimal dollars that you're asking for. You're not hiring a whole bunch of new people. You're not going and investing in all new platforms. It's really taking what you have and just making it more efficient.
Great. Thank you both so much for weighing in there. The next question I have is, the value of a referral is an interesting concept. So how do you account for no-shows, cancellations? In other words, how do you pull through rate calculated?
Yeah, so
how is a pull-through rate calculated? Sorry about that.
No, that's fine, and that's important. So when you're trying to understand, and that all folds into that value of a referral. It's part of the calculation, understanding that every time I make a referral, what is the percentage of patients that are actually going to show up with an appointment. And so you take your actual claims data, that you're paid on, your hospital inpatient, outpatient claims data, and you put all the referrals, whether they showed up or not, into the denominator, and then look at what percentage of those are actually coming through. So do you have a 12% pull-through rate, meaning that every time I make a referral to a specialty, that there's a very low percentage that patient's going to end up in my health system, or is it much higher? And of course, through this work, you're constantly monitoring that and working to increase your pull-through rate, and that's calculated at the specialty level too, so that you have further insight into maybe it's an issue with certain providers or a certain specialty that can be more focused on.
Yeah, great question.
Excellent. And so the next question I have here, I think we've talked a bit about how this works in an ACO or CIN environment, but this next question dives into that as well. So this attendee asks, what are you seeing within ACOs or CINs for in-network referral improvement, since Stark and anti-kickback rules are more forgiving?
Yeah, I mean, so I touched on this a little bit earlier, that it's really good to see the Stark and anti-kickback statutes, which have great purposes and really have protected us, as a healthcare system over the years. Really appreciate that this is really around total cost of care and total quality management of a patient, and the importance of them, staying within network. So, I won't go back over the previous answer, but what I will say, is that we're seeing that the CIN and ACO's governance, that they will actually remove physicians or have criteria in the membership or in their operating agreement that addresses this. So again, I think that really, says a lot, because this isn't around, a health system situation, that can be said, hey, this is all a volume play or this is all a numbers game. No, this is really a big deal. And so it is becoming a lot more aggressive. It's becoming more uncommon to see ACOs and CINs not have contractual language in their agreements that addresses this.
Excellent. Thank you for that. And as we're nearing the top of the hour, I just want to ask David or Austin if you have any final thoughts you'd like to share with our attendees today.
No, I would just say that, one, even when you see the kind of questions that folks are, it's always refreshing to us to kind of, hear that level of interest and the level of detail that you have to get into for these programs to work. So, so I would only just, close out, by saying this is something that really is, critical. We have kind of swerved around physicians for a long time in healthcare and not taken this head on, and I think the patients have been the ones that have suffered. And so I would just hope that folks would really see this as more of the right thing to do, but just as it turns out, it has some great quality and economic benefits to kind of propel this in an area where we have scarce resources. We get it. So I think this is what I call a self-funding strategy.
Fantastic. Some nice closing thoughts there. And that is all the time we have for today. I want to thank David and Austin for their excellent presentation and BRG Prism Healthcare for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thanks. Bye, everyone.